And hello everyone. Welcome. We're getting feedback. Let's turn off. The wonders of technology. There we go, getting feedback. My name's Kane Treble. It is Tuesday. We are here for a final run through of CCE exam practice. Hopefully you're all doing well. Hopefully we've got a few people here tonight that want to jump in and give it a go before the CCE exam. So RACGP 2024.2. Time is almost up, guys, and I know a lot of you must be very nervous, but I want to reassure you guys, this is an exam that most people get through without any troubles. Nerves aside, the fact that you're watching this says you're putting in some effort, and I think you're going to be just fine. Of course, let's give ourselves the opportunity to practice. I've got 3 cases prepared tonight. Admittedly, these are cases that are maybe have a little twist or quirk to it, so the point of these is to challenge you with a few more ideas that maybe you haven't practiced on as much so far, to give you the chance to get a last bit of time in to actually improve your chances of passing this exam coming up this weekend. So, bringing up, we have here, of course, that we are struggling with our IT tonight. There we are. We are 4 days to the 2024.2 CCE exam. And we have a few more tips that I would love to run through. I want to make sure you're aware of all the potential traps before the exam day, and some things that you may not have thought about so far is that this is an exam that you often feel like you're supposed to be solving every problem and going in to fix everything on your own. One of the best things about general practice is just how collaborative it is. So I want you to utilize that in the exam. So if you think that a specialist referral or MDT kind of collaboration is indicated, this is the whole point of doing care plans, use it. Try and use specific phrases and practice things like, I believe this case would benefit from the expertise of a specialist. And I'll coordinate that for you. That again reinforces the role of a GP as the central coordinator for a medical patient. And reflects the maturity in managing the complex cohorts that we see day to day. Now, of course, there's going to be ambiguity, and as we've said time and time again, ambiguity is the bread and butter of general practice. So when faced with vague case details, try to embrace that ambiguity and prioritise a safety plan to make sure that that patient gets the care they need. And you can verbalise this by saying, while this seems straightforward, let's discuss the warning signs that might prompt an immediate return visit. Have a specific phrase that you use that lets that patient know these are the red flag things you need to be looking out for to escalate care. And of course, ethical dilemmas and boundary settings, some foreshadowing for tonight perhaps. Cases are often chosen to have ethical grey areas. So refusing treatment or seeking unnecessary interventions for a child. This can catch you off guard if you haven't thought about this beforehand. So try to think now, you still have days left to prepare. Think of a framework for your ethical decision making, such as the 4 principles of autonomy, beneficence, non-maleficence, and justice. I want you to have a few bullet points that you can go to at the drop of a hat to prepare yourself for these kinds of scenarios. Again, verbalizing. While I respect your wishes, I also need to ensure that we're acting in your best health interest and not causing any harm. Now, often we see difficult patients in clinical practice. We all have our ways around it. The CCE exam is no different, and sometimes we're given an intentionally difficult patient to see how we respond. So when dealing with this kind of confrontation, try to master those de-escalation techniques such as reflective listening and non-confrontational language. Things you can, phrases you can try and use is, I understand this must be incredibly frustrating. Let's work together to find a solution. Now, this gives the ability to work with the patient, get the patient on board to say, this isn't a case of us versus them, this is a case of us versus a problem, us together, let's tackle this together. It's that collaborative approach. And of course, a part of that as well, if you haven't already kind of honed in on your own, try to think of what your biases are, because we're all going to experience some of these. Now, as humans, we will experience anchoring bias, confirmation bias, or premature closure. That can compromise some of our decision-making decisions. So try to challenge yourself by considering alternative diagnoses, and especially if new information arises during the case. You might think you're heading down one pathway and have prepared a set of responses based on that. and they may give a pertinent bit of information that actually means you need to sidetrack or derail where you thought this was going to prioritize the actual problem for the patient. Again, verbalizing. So initially, I thought this might be X, but with these new findings, I actually need to reconsider that to Y or Z. Now, it's this level of adaptability and ability to think on your feet that I think, again, is done by GPs all across Australia. Of course, be forgiving with yourself and your self-doubt. There's a lot of expectations coming into these exams. I know a lot of people have big things, big aspects of their life that have been put on hold for a very long time to get through this. Odds are you're going to make some mistakes in this exam. Everyone does, and that's okay. Embrace the reality that mistakes are just a natural part of any exam, even for the most experienced, prepared candidates, and that an error in 1 or 2 cases does not mean you're going to fail this exam. Instead, use that as a chance to say, okay, I know I made that mistake. I'm not going to make that mistake in any of these other cases. It's this show of resilience after a misstep that can also actually work in your favor. Because if you can go into a case and say, look, I think I've gone off on the wrong track here. We still have a bit of time left. I'm just going to take a moment, recenter myself, and let's tackle this with a fresh set of eyes. Pause, catch yourself, and try and have a different approach in there. The clock is often in your favor. At the end of the day, each case is independent. So one slip up can be offset by strong performances in other cases. You can make up those marks elsewhere. You've prepared thoroughly, and one mistake does not define your overall capability. Refocus on what you can control, like moving on confidently to the next case. And of course, I just had to use that animation there. It felt so right to just scrunch up the last case you did, move forward again. Of course, we have some cases prepared tonight, and popping into the chat here, I'm going to have a link through to Zoom. So if you are preparing for this week's exam, I would encourage you strongly to jump on in. We are going to bring in people into Zoom. Oh, don't want to give it away too early. And see if we have anyone that would like to participate. Now, I appreciate that a lot of people are probably nervous. There's people that may not necessarily feel that confident. I would again encourage you to use this opportunity to jump on in and give this a good shot. Now I can see we have Demir joining in. Great to have you here, Demir. I'm just going to get the screen prepared if I can. Now hopefully you can see me and see the screen there. Is that correct? And can you hear me? What? Can you hear me there, Demir?
Yeah.
Fantastic. I'm just going to get this screen prepared. And all right, the wonders of technology. Just screen 4. Let's bring you up here, and if you are happy, you can read the screen there. You have control of the screen.
Just give me a second.
Perfect. Yep. Excellent. Well, let's get 5 minutes on the clock, and your time starts now. waiting time is up. Your case time begins. Oh, hey, Doc.
Hey, Peter.
Yeah, how you going, mate?
Peter. I'm alright. What can I do for you, Peter?
Yeah, look, I thought I'd better come in. I'm just feeling flat all the time, and I'm not really sure what's up. I'm just sick of it.
Yeah, I'm sorry to hear it. I understand it's been going on for 3 months now. Is that right?
Yeah, about 3 months.
Yeah, okay. Well, look, can I ask you a bunch of questions first, okay?
Yeah, sure. Go for it.
What else can you tell me about what's been going on?
I guess it's just been kind of slowly creeping up. At first I just thought, oh yeah, work's getting a bit busy, and a bit run down. But there used to be all things I would like to do. I love going hiking on the weekends and stuff. But even that's kind of not really on the cards anymore. I'm just too tired even when I wake up in the morning.
Yeah, right. Okay. And do you reckon it just hit you one day, or it's been steadily building up?
I'd say probably steadily building up. Yeah, kind of just snuck up on me. I can't really put my finger on one exact day that I felt like it started. It's just kind of crept up.
Have you ever felt like that before?
No, I never had anything like this before.
Have you noticed anything else unusual, out of the ordinary, last 3 months?
Hard to say, like what?
I'm gonna ask you some more sort of direct questions. I just want to open the floor and see if there's anything that comes to mind. If nothing specific, I'll go and ask you
No,
something.
yeah, go for it. Yeah, far away.
Yeah. All right. So look, fatigue is a kind of thing where there's 20 different things that can cause it. So I'm just gonna go through what it could be and ask you some directed questions on that.
Yeah, sure.
I understand you've been losing weight.
Yeah. Fair bit.
How much do you think you've lost?
Oh, look, over the last 3 months, probably about 3 or 4 kilo, I'd say.
Okay. Bit of a silly question, but have you been eating well?
Yeah, appetite's pretty good. If anything, I'm kind of craving a lot of junk food, I guess.
Yeah, really? Okay. Yeah. Do you feel like you've been eating a lot, drinking a lot more than usual?
Yeah, probably drinking a bit more. Yeah, now that you pointed out.
And are you peeing a whole lot as well?
No, not really.
There's been some nausea, I understand.
Yeah, just off and on feeling a bit seedy. Like at the moment, I feel like that's gotten worse. Feeling like, just hungover kind of sensation. Like sometimes when I get up, I got that kind of groggy, dizzy kind of feeling as well.
Is everything spinning, or are you just feeling lightheaded?
I guess probably a little bit of both, really. Yeah.
Okay. Have you noticed any lumps or bumps around your body? We'll call them lymph nodes. They're usually in your neck and your groin. Yeah. Okay. Any black poos?
No, bowels have been normal.
Like my
No.
headphone. No. Okay. Have you been bleeding from anywhere?
Not that I can think of.
Have you been unwell, like running a fever or an infection in the last 3 months?
No, but I just feel like I've constantly got that kind of about to catch a cold kind of feeling.
I understand. Okay. Any travel overseas last 6 months?
No, I wish. No, work's been so busy. It's really just go to work, come home again.
Okay, no problem. Have you been coughing at all?
No.
No. And you're a non-smoker, never smoker?
No, I never smoked.
Never smoked. Have you ever been exposed to coal dust, silica dust, asbestos?
No, I work in construction, but I'm a project manager, so more indoors kind of thing.
You're not on site with a respirator and stuff like that? Okay. Have you had trouble with shortness of breath?
No, not breathlessness, just tired, if that makes sense.
Just fatigue. Yeah. Okay. When you try to do something that really makes you feel tired. Do you get any chest pains?
No, nothing like that.
No. Climbing a flight of stairs, suddenly clutching your chest, out of breath? No.
No.
Any palpitations? Feel like
No.
your heart's racing, skimming beats? No. What's been happening at home? Do you live with anyone? Do you live by yourself?
No, I live by myself. Everything there is going pretty good at the moment. Work's busy, but we've got a couple of big projects that are finishing up, so I'm looking forward to that. Yeah.
Okay, good. And apart from hiking, anything you do in your spare time?
I used to take apart and put together old watches, but I haven't really done that for a little while. That's been more time than anything else, I think.
Do you feel like you've been depressed or low?
No, I don't think so. I did worry about that for a bit, but like my mood's okay. I just feel tired. Like no matter how much I sleep, it's like it's never enough.
And speaking of sleeping, I guess you haven't got someone there to tell you if you snore?
No, but I've got one of those smartwatches that tells you, like, if I've gone out to after a work function, had a few drinks kind of thing, it'll say I've snored then, but the rest of the time, no.
It's quite a watch. All right, fair enough. But you wake up quite groggy? Did you say that?
Yeah, like I start the day feeling like I'm ready to go to bed.
Gotcha. All right. Do you take a lot of naps through the day?
I wish I could, but work's pretty busy, so don't really get the opportunity.
Fair. And have you been really anxious about anything? Just non-stop worrying?
No, as I said, it's kind of more excitement, if anything. A couple of big projects wrapping up. So.
Constipation? Diarrhea?
That's been pretty normal.
Yeah, all right. Feeling cold when everyone else isn't, or feeling hot when everyone else isn't?
Not that I've noticed. But I mean, I'm working in a like temperature controlled environment, so it's always just the same.
Fair. Okay. Any changes to your skin? Rashes? Suddenly the skin's gone a different color?
Not rashes, but like kind of over my knuckles and fingers, the skin's gone a darker color.
A darker color.
Yeah. Okay. At first I thought it was bruising or something, but it kind of doesn't feel like it's bruised. Darker.
Would it be like an orangish?
More brownish.
More brownish, yeah. Okay, all right. Okie doke. I know you've got a bit of alcohol now and again. Any recreational drugs?
No, nothing like that.
No, nothing injectable.
No, it's never been my scene. I've always been a bit of a workaholic, so.
Right. Okie doke. Now, just bear with me.
Yeah.
I'm gonna go through a bit of a. So I've asked all the questions that I wanted. I'm gonna go through a bit of a differential with you in terms of what I'm thinking.
Yeah, that'd be great because I've got no clue what's going on.
Yeah, look. To be honest, in a young fellow like yourself, fatigue can be a lot of different things, and most of the time fatigue is something lifestyle related, working too much, depression, anxiety. But when we got fatigue and weight loss at the same time, that's a bit of a red flag for us, that something's going on in the body. The body's using up resources more than there are resources coming in. The other thing is with your blood pressure being a bit low and that discoloration on your knuckles that you described, I think what might be going on is a problem called Addison's disease.
Yeah, right.
Have you ever heard of that before?
No, what's that?
No. You know you've got your kidneys on both sides?
Yeah.
And then on top of the kidneys, you've got these glands called adrenal glands, and they secrete a bunch of hormones. And among other things, they secrete a hormone called steroids. Steroids help you keep fluid in the body, okay? And they help you keep salt in the body. When you've got a problem called Addison's disease, for some reason, your adrenal glands are not making enough of that steroid. And so what happens is, your body loses salt and fluid. That makes you feel lightheaded. And it makes you feel super tired. And you can even lose weight on account of it.
That's me. Yeah. Oh, so that's why I'm craving all the salty stuff.
Yeah, that would fit the bill. that would fit the bill. Alrighty.
What do we?
I'll just
Is it like a test for that, or how do we know that's what it is?
Absolutely. I'll just briefly list, for the sake of posterity, a bunch of other things we're thinking of. Various cancers, doesn't sound like that's going on. Diabetes is something I'll test you for, but it's probably not it. Infections like tuberculosis, anemia, lung disease, heart disease, mental health problems, thyroid disorders, I'll test you for that just in case. Iron deficiency, sleep apnea doesn't fit the bill for you, and substance use. So what we'll do a targeted number of blood tests for you.
Yep.
We'll check your thyroid, full blood count, kidney function, liver function, iron level. We will check you for Addison's. So that would be a late night salivary cortisol test. Okay, it's a bit different. What you'll do, I'll give you the form, and I'll get you to go to a pathology place. They'll give you a bunch of containers. You're gonna have to spit in them.
Spit in them. Okay. Right. Okay.
Yeah, at night. So before you go to bed.
Like a particular time, or
they'll tell you. They'll take you through it. Yeah.
Right. Okay.
The pathology people that you go to next door, they will take you through how to do it, and then what to do with the containers and bring them back. I know it sounds a bit odd, but that's the best test for us to see if your steroid levels are low. Okay.
Right. Okay.
Hold on, just bear with me. I'm just double checking that in my mind. No. Hold on. Sorry, that's a different test. That's a test to see if your adrenal glands are overactive. For underactive, we do a morning blood test. Okay, so forget the spitting.
Okay. No spitting. Okay, good.
No spitting.
Oh, yeah. Excellent.
Morning. It'll be a morning fasting blood test.
Yep.
For a drug for a hormone called cortisol. That's the steroid in your body I was telling you about.
Yep.
And then we'll do a bunch of those other tests. I don't think you need any scans yet.
Yep.
Or any other tests yet. If we find that the cortisol is low, what we're going to do is a few things. Okay. So number one, we're going to put you on steroid tablets in the meantime, and they'll make you feel.
Doc, you're going to turn me into a gym junkie.
Different kind of steroid.
Oh, okay.
Different kind of steroid.
Oh, good.
It'll just replenish what your body was missing.
Yeah. Okay.
And I'll double check on the day, but it'll be something along the lines of hydrocortisone plus a mineralocorticoid tablet. I'll be more specific on the day when I can double check with the Australian Medicine Handbook.
Yep.
We're going to then run a scan with contrast on your adrenal glands to make sure there's no tumor. And then we will send you to a specialist urgently called endocrinologist. They are the people who look after hormones in our
parents
body.
had to go to them. They had diabetes and rheumatoid and all kinds of issues. So
Yep.
I'll get one of my own, family tradition.
Well, you might get a family discount if you go to your parents' ones.
Oh, Bill.
Yeah.
Cool.
3 for the price of 2. And other things. So, did you want to ask me something?
Yes. I just take a tablet and that kind of fixes it. That sounds pretty good.
It depends on what the cause is. This is going a bit above my pay grade in terms of depending on what the cause is, what's going to happen. The endocrinologist will take you through it. Sometimes you need to have surgery. Sometimes you need to go on medications.
Right.
But in the meantime, these steroid tablets will tie you over. Okay.
Yeah, good. Okay. Is there anything I can do just for the dizziness as well?
Yeah. So take it easy when you're getting up. Okay. Your body is fluid depleted, if you know what I mean. There's not a lot of water inside.
Yeah.
Because there's no salt keeping it in. I would actually maybe take a salt tablet or take more salt in your diet right now.
I'm just going by Macca's and getting chips every day. So yeah.
You know, in the next week or so, that'll do. Long term, probably not the best idea.
No.
Something like Gastrolite or Hydrolyte will probably be good, and add a pinch of salt to that. If you feel really lightheaded and just passing out, just go to ED, go to emergency, okay?
Yeah, okay.
And I will see you when the blood tests are back. So let's see each other in a week or two.
Fantastic. And that is your time as well. Really, really happy you snuck in right at the end there, the follow-up plan as well. So just in the nick of time, very well done. So 100% correct. This was Addison's disease. When was Addison's kind of on your radar? When did you start to pick up on it?
Well, I had a list of 15 things. Addison's was number 10. I just, I mean, you know, the postural drop, weight loss.
Yeah.
But when you told me about the knuckles, I thought, dang.
Well done. If I can get back, I'm just going to bring up on the screen across. No, that's not going to work. That's okay. So the case was Addison's. It was intentionally supposed to start off vague and get you to kind of tease out exactly what it is. And so part of that then is differentials and sorting through, coming to an appropriate diagnosis. You're 100% correct. It's the morning cortisol test for Addison's. I really liked as well the way that you caught yourself and said, oh no, wait a minute, I know that. And again, that's what you'll do in real life. That's what they're happy to see you do in the exam as well, because it's not saying, you know, you're a bad doctor, you don't know it straight away. It's okay, you've caught yourself, you've corrected that, the patient now has a safe management plan, investigation plan, spot on. So really, this case is to recognise and manage the first presentation of adrenal insufficiency, emphasising that history-taking aspect, identifying those key symptoms and educating around what is our initial investigations. Would there have been anything else you would have added to your kind of management plan? Or I like you stuck in there about if you're feeling bad, go to ED. Is there anything else about Addison's, you know, if they become unwell? No, that's right.
Like a sick day.
Yeah, perfect.
Thing.
Yeah, sick day plan.
Yeah.
So they'll need to have the hydrocortisone there. But at this point in time, you just be flagging, you know, hey, you mentioned you feel like you're always getting a cold. If you do get a cold or get an illness while we're investigating this, you probably do need to go straight to ED to get some blood tests and just be on the safe side. But otherwise, mate, absolutely smashed it. Clear pass for this case. You're sitting this weekend?
Yep.
Excellent. Well prepared, mate. You're going to be fine. Cool.
Cheers. Thanks, King.
Anytime. I'll pop you through if you want to jump back onto... The wonders of technology. So far into a pandemic and I still mess this up every time. There. All right. So, come back to the presentation and I will bring back to the screen there. So, as we're talking about then, the competent candidate for this case demonstrates an understanding of the signs and symptoms with adrenal insufficiency, including, as he correctly picked up, the fatigue, the weight loss, the hyperpigmentation, as well as those red flags in terms of the postural hypertension, salt cravings that support the diagnosis. Very appropriate investigations. I love the way he kind of rapid fired out a wide net of things. You know, hey, this is most likely, but we need to check for those other things. That was very sensibly done. The communication style was fantastic as well. It was clear, it was empathetic. There were a couple of little jokes in there to build up that rapport. And normalizing the information of, you know, hey, this could be something here, there could be something to it, but it's something we can get on top of. I think having that nice, calm demeanor really worked in your favor there. As well, reinforcing that the investigations are really going to guide diagnosis and subsequent management, but making sure there's that interim management plan for the next step in case things go well and in case things don't go well for that patient, and a very sensible approach to have that follow-up plan to just snuck it in there for the 1 week time. Now, coming in from the chat, we have from Kashminda here, a handout for Addison's disease, the bracelet action plan in case of crisis, fantastic. These were things, so the handout for Addison's disease I would be giving on this consultation. Bracelet and action plan, well, bracelet I'd probably be doing once the diagnosis has been confirmed. action plan in case of crisis. I think as long as you're verbalizing, you know, hey, if you do get unwell, seek help straight away, because that can actually become a big problem. And as you've correctly identified, the Addisonian crisis is the big thing we're all keen to avoid. Now, we've got more cases. Hopefully, people would like to jump in. If you are keen to have another crack at it tonight, pardon me, I will pop into Zoom there, and we'll see if anyone else would like to jump on in and try out a second case for themselves. I will sure when you actually join, you're going to be able to see the case. There we go. I'm trying a slightly different IT setup tonight. I try to make this work. It doesn't always work, but I have fun with it anyway. If you do want to jump in, please join via the link in the chat. It's a Zoom link there. It is the same setup you'll be using on the exam days. This is a great opportunity for you to jump in and try it out in a safe environment. Muck up the tech or anything now. Find out now what's going to work and what's not going to work for your computer, for your setup. And hopefully get a bit of practice at a case as well. Of course, if we don't get anyone jumping in, that's fine as well. I'm more than happy to just run through the case as it is. Demir, if you're happy to do a second case, if you want to give it another, say, 10, 20 seconds, but otherwise, if you want to jump back in, I am happy with that. Again, for people watching, just make sure you're also watching this live so you actually get the opportunity to jump in at the right time. If you hover over the screen, you should have the little live button down the bottom. It should have a red dot next to it. If you have a grey dot, it means you're actually behind. Your internet connection may be buffering or something's happened to slow it down. Make sure you're watching live so that when we do this call out, you've got the ability to jump in. Well, Demir, it may be your, we'll say lucky night. If you're happy and willing to jump back in for a second case, we'd love to have you back. If you're not sick of me, of course, that is. That's always a possibility. And I'll warn as well, this next case is again intentionally a little bit more on the difficult side to challenge you on things that you may not necessarily have prepared for. But again, I want you to challenge yourself now and see how you go on the day. Okay. Unable to rejoin meeting. Well, I guess that is Zoom deciding for you. I'm very sorry. So for those that have just joined, I'll just pin a message up the top. If people want to jump in and try one of these cases out, click the link, follow through to Zoom. Otherwise, we'll give it another 20 seconds, then I might just talk through the case then. Thanks to Mia for the offer. Looks like tonight's not the night to try it again. All right. So, that's fine. Let's run through a case. I will get the screens ready, the wonders of technology. Is there... Oh no, we do have Keshminder joining in. And
Hi.
Keshminder, can you hear me?
Yep, I can.
Excellent. Can you see the screen okay? You're able to see the screen as well?
Yep, I can see it. Yep.
Beautiful. Okay. Well, if
Yeah.
you're happy then,
Yep.
we can put 5 minutes on the clock and your time starts now. Your reading time is up. The case time begins.
Hi,
Oh,
Michael.
hey, Doc. How you going?
Good. How are you?
Oh, yeah, been better to be honest. It's been a rough couple of months.
I see you brought Emma. Is that your daughter?
Yeah, my daughter. Yeah, she's 4 now.
Okay.
Grows up so quick.
Yeah. How can I help you today, Michael?
Yeah, look, I'm just worried. We heard there's been more measles outbreaks in the state. Our school recently had a chickenpox outbreak as well, which
Yep.
this day and age, I thought everyone was immunised, and I guess that's part of the problem. Really, is Emma never got any of her immunisations. Her mother, oh, she always anti-vaxxer, and no matter how much I tried to convince her, just flat out refused. So is there some kind of like catch-up program we can do, or some way to get her topped up and back on the
Oh,
schedule?
yeah. We do have a catch-up program. So, could I just ask you a few questions
Yeah, of course.
before we start off?
Yeah.
So, Emma, has she not had any of her immunizations since she was born, or?
No, since she was born, her mother is into the whole
Yeah.
alternative living thing, which,
Yeah.
you know, back when we were dating, it was fine, but, now we
Yeah.
got kids. It's one of the reasons why we ended up splitting up, truth be told, was just different parenting thoughts and styles.
Yeah.
Yeah.
And have you guys discussed in length about it with with someone else or any doctor or nurse or what regarding this
Uh,
decision?
well, a couple of years back, I think she was
Yeah.
1 or 2, she had fallen over and scraped her knee up pretty bad, and the doctor
Yeah.
then was asking about, immunisations and tetanus shot or something, and
Yeah.
yeah, my wife just lost her mind. Went on this big rant about how they're dangerous and cause
Okay.
autism and things. So yeah, it never
Right.
got followed
Right.
up on.
And Emma has never had any immunization, and she never had any adverse reaction from any immunization that you know
Well, she's never had them, so
of?
no
Okay. Right.
reactions.
Right. And she's not allergic to anything that you know of?
Her mother says she has all these allergies based off some homeopathic test thing they did,
Yeah.
but she's never actually
Yeah.
reacted to anything and never had any rashes or anything. So yeah, I don't really
Okay.
know.
How are you? I'm sorry to hear that about your recent divorce, but how are you coping? How's your arrangement with Emma with your ex-wife regarding the care for
No,
Emma?
yeah, I'm fine. Like it's been years in the making. We kind of saw
Yeah,
it coming for quite some time.
yeah,
Obviously, we've got very different worldviews.
yeah,
Um, we're doing joint custody at the moment, but
yeah.
it's doing my head in. I'm going to try and put in to try and get more custody. I think we're trying to do alternating weeks, and it's just so disruptive
Okay.
for Emma.
And have you all went to the courts or anything, to discuss this matter? Like what sort of, the health and financial matters or anything like that? Have you all had any discussion about that?
No, not really. Is there? What are we
Yeah.
supposed to do for that then?
Okay. Well, uh, for Emma to get the immunization,
Mm,
unfortunately, it's a bit complicated that because two parents are not agreeing and not seeing to eye, and we don't have actually paperwork to see who has that sort of right. So naturally, we need both parents to agree.
Right.
But also, the other thing is there's a lot of uh, child center, daycare center. If your child is not immunized, they might not allow your child to participate.
Yeah, well, that's one of the problems we're having is she
Yeah,
was in one place that was a alternative
yeah,
kind of place. I actually don't even know if it was actually registered, truth be told. And
yeah,
we're trying to find new places for her now because we're living a couple of
yeah,
hours apart.
yeah.
And yep, struggling to get in anywhere. I mean,
Okay.
surely, like everyone says you need to have it done. Can't we just
Yes.
do it?
Yes. Not really. So it's a bit tricky. So what will be the case is you will have to go through a court proceeding, and obviously the court is going to finally decide on the child's best interest,
Right.
and
Does this
that's
happen all the
how.
time or?
Uh, let's just say it's not something that is often happens, but it do happen from time to time. But the law, whenever there is two parents who have different ideas and different expectation, the law will decide on the child's best interest. So it could be the case that the law decides that the Emma can have the needles, and that's it. But you just have to go through court proceeding. Legally, I can't. But one way is I could schedule a meeting to speak to Emma's mom, if she's happy to have a chat with me to discuss about her worries about the needle, especially with the autism side of things, because we know now that it's all been debunked and it's not true that
Yeah.
autism is caused. And I don't want to discredit Emma's mom. I'm pretty sure she would have did her own research, but sometimes some of the things that we get from the internet might not be from the right source. And I'm happy to point out and have a discussion and all that.
Oh, that'd be great because she's on all these Facebook groups that all just kind of feed
Yeah.
into each other.
Yeah.
Yeah, no, that'd be amazing. I mean,
Uh,
bring earplugs because she's gonna lose her mind, I'm sure.
oh,
But
we doctors always have, patients who might have different sets of belief and all that, but we are here to help, and we are here to, to set things clear and, to point the patient to the right pathway and stuff. Because as you know, without the immunization, Emma has a risk of getting severe infection like, measles. The immunization is not 100%, foolproof, but it does protect Emma against this vaccine preventative disease.
Okay, because that's my
Uh,
worry is there's all these
yeah.
outbreaks of stuff and she's not protected. So
Yeah, I do agree. I think it's fair if Emma can come, Emma's mom can come along, and if she's happy to sit with you yourself and we can have a discussion. I'm happy we can do that face to face. I can bring some handouts to explain what I'm gonna say, and maybe it might just take some time for Emma's mom to understand what's the benefit from getting the vaccination and all that. There are risks also as well with the vaccination, like some child can get a bit of fever, a bit of pain and all that, but it's not something really serious. The most serious thing is probably anaphylaxis, but I wouldn't say that's something very common. It's in some of it is in a million chance actually.
yeah, okay,
Yeah,
better
but
than getting measles, I guess. So.
yeah, but how's Emma taking with all this divorce, like with both of you all, going your
Yeah,
separate
to be
ways?
honest, we've been fighting for as long as she's been alive, so I think it's just kind of part of the package
Mm,
for her. Um,
yeah.
she's doing pretty good. She doesn't
Okay.
fully understand everything that's going on, but just knows that back and forth, back and forth. And I think,
And is she in a? Are you a stay-at-home dad, or who looks after her,
yeah, I'm
or
pretty
something?
lucky. So I do. I'm a truck driver, so I do lots
Yeah.
of long hauls. So I'm able to kind of plan out my week so that I do a
Yeah.
week where I'm pretty much on the go non-stop, and that's when she's with the mother. And then
Okay.
I get a week off and I can just be with her at home all that
Mm.
week. So that's
Okay.
working well. But I'm thinking I might try and pull back hours because I can actually
Yeah.
step into a more office kind of role.
Yeah.
And I'm not getting any younger, so
And
and that would mean I could potentially keep her with me. Getting her
yeah.
into childcare though is the hard part right now because, as you say, no one
Yeah.
will actually accept her.
And has did you had any concerns with Emma's development per se?
No, she's a little champion.
No.
She's four
Okay.
going on 40. I swear they grow so quickly. Yeah.
And how's the interaction? Do you have any other kids, or is this the only daughter
No,
that you
just one. We realized quickly that even for the both of us, one was probably a mistake and
have? Okay.
probably wasn't fair for Emma, truth be told. But here we are.
Okay. Right. And do you have a partner now, or are you just
No, I'm having a break.
okay?
Yeah,
Right.
yeah,
Right. Right.
yeah.
Right.
Well, Emma is more than enough for my life, right?
Oh, okay. Um. Uh.
I mean,
The.
could I
Yep.
just kind of I've seen ads for like the immunization clinics.
Yep. Yep.
I could just kind of take her there and not mention anything about her mum. They might just do it.
Um, well, you're right in that sense. They might, if you don't say that. Uh, but then that would be something pretty hard actually, because sometimes not every doctor will ask, are you all separated or anything like that. So if that happens, uh, the court will also see in the favor of the child also as well. And I'm assuming that that doctor probably have to speak to his medical indemnity also as well to get. Uh, but the ideal way is actually with separated parents is both parents need to come agreement for the child's welfare
Yeah,
and
well, I
stuff.
don't want to get a doctor in trouble. That's
Yeah,
okay. That makes
yeah.
sense. And
It can be very mucky, like if Emma's mom decided to take the doctor for legal suit and all that. It can be
hmm.
quite a case and all that. I wouldn't really suggest doing that. And I think the best way is one way is like I was saying that if we can sit down on a and discuss. If we can't get a resolution or some sort of agreement, then I guess moving forward is actually you guys will have to engage a lawyer and go from there, the court proceeding.
All right, doc. I
Yeah,
guess that's just
and
what we'll have to do.
once we already
Yeah.
have that, I can talk to the public health and we can come up with a schedule for catch up
Yeah.
vaccination and all that.
Oh, that'd be great. I
Um,
mean, would you be happy to just kind of prepare that? So
no,
that
yes,
when she,
yes,
because
yes,
then
yes.
she can kind of have a look at that, I guess, and
Yep,
um,
yep.
we could run
I
through
can
that
show
as
it
part
to
of it.
Emma's mom also as well, what we
Yeah,
work
yeah,
and
yeah. That's what I'm meaning.
can do
Yeah,
and stuff. Usually after the vaccination, I usually give a handout, what are the things you need to watch out.
yeah.
But it's just a simple handout and all that, nothing too complicated and stuff.
Uh,
Um,
I think simple would be good for her, if you know what I mean.
yeah, yeah.
Hmm.
Um, Uh, how is the other thing I forgot to mention? I
Hmm.
mean, you were saying that she's growing too quick, and you're happy with how she's growing. How's the diet like and all that? Good.
A bit of a fussy eater, but
Yeah,
I think it's within the scope of normal, I'd say. So I think all kids go
yeah,
through a phase where they just want chicken nuggets and
yeah,
sauce, but yeah, we
yeah.
try not to give it to her too much, of course.
Okay, I
Mm.
do. Is there anything else that you think I should talk about that I might have not covered or anything?
No, look, I think you've covered all my things. I think we probably need to go back to the lawyers again, have a chat
Yeah,
about that. But yeah, if we can tee up that meeting to kind
yeah,
of run through everything, if you've got the handouts and a schedule together,
yeah,
that'd be amazing.
yeah.
Um,
And I'm
maybe we can talk
happy,
sense.
because for a child that is uh, coming out from having a parents who are separated, sometimes they can be affected mentally, and it's kind of hard sometimes.
Hmm.
And I sometimes do like to take history from both parents, like even Emma's mother, if she did
Oh
notice
yeah,
any changes in
yeah,
terms of um, Emma's mental health and all that. Worthwhile, we get that also
yeah. No,
organized and
I mean,
stuff.
to her credit, my ex, one thing she is big on is
Yeah.
she loves her kids. So
Okay. Excellent.
yeah,
Yeah. Yeah.
I think that'd be
Yeah.
fine. Yep.
I'm sure we can always get something worked out actually. It's just sometimes it might just take a bit of time.
Mm.
You might not need to go to the court. Like I said, the first step is coming to the doctor's consult so that we can talk about this and go from there.
All right. Okay. Well, I'll go see reception, I guess, and make that extra appointment. And
Yep.
yeah, I'll
Yep.
give her a phone call and tell her to come over.
Yep. Yep. No worries.
Mm. You have 25 seconds left to do with as you please. And you will get, on the day as well, you're
Yeah.
going to get probably multiple cases where you feel like you've got this extra chunk of time at the end.
Yep.
That's fine. If you quickly go through your notes again, if there is something else you want to bring up, it's always a great opportunity to just sneak in last minute. But
Yeah,
that's your time there. Time's up.
I should ask about what do you think about autism for the vaccination and stuff?
You actually did. You actually did assess my beliefs there, and I said, oh yeah, no. So that was fine. What a case.
Yeah, it is quite tricky actually. This case.
Yeah. And you did fantastic as well, I have to say. This is an intentionally difficult case that's designed to trap you a little bit and to tease out, one, what do you know about the Australian legal framework? And as you very correctly and appropriately identified, this was not a kid that you could immunise. Now, there is going to be variation location, so it's all going to depend a little bit on where you're based. But you're correct that for most places, you need both parents' consent in order to do anything to the child, especially if there isn't clear legal frameworks or guardianship orders in place to determine who has the right to make medical decisions for the child. So I really like that you spent that bit of time at the start teasing out kind of, were orders in place? Is this something you guys have discussed? You very quickly identified that, the mother probably wasn't going to be consenting anytime soon. I liked as well that you went through kind of a framework then of ways to get that on board. So bringing the mother in for chats, preparing handouts, preparing resources, absolutely fantastic. Going through the appropriate legal channels as well was a big tick in your favour. And I wasn't sure if you were going to mention, so I did tease out, admittedly, I'll just go to another clinic and just say the mother consents or just get it done there. I think you did well to kind of point out, hey, you're actually going to get someone in trouble for doing that. Although I am aware that is something that some places may do. And this is also why whenever you're doing vaccinations, really, really important to ask and document appropriate consent has been obtained. And it's tricky. We can only protect ourselves so much. If people are going to lie or do things dishonestly, they're going to. But it's why we write very detailed notes to make sure that if anyone comes knocking on our door saying, hey, you vaccinated this child without consent, that we have something to go back to say, no, we got that consent there. Now, there is the RACGP pre-immunisation kind of checklist that you can run through, and I would always encourage everyone to have a copy of that scanned to files as well. To, one, do best practice, but also cover your own backside. Well done. Very well done. That was, as I said, an intentionally difficult case, and I think you absolutely smashed it, mate. You are prepared and then some.
I hope the CCE will be not too hard this time, actually. I'm just very nervous sitting it for the second time, actually. I don't know what to expect again.
If you do half as good as you just did, you're fine. Yep.
I just want to pass this.
Yep. No. I think you did really, really well there. So well done, mate.
All right. Thanks a lot, Kane. Thank you so much.
Anytime.
Yeah.
All right. So I'll just quickly step through the feedback for this case as well, and I need to switch the screens. So for this case, the competent candidate demonstrates an understanding of the custody and legal arrangements related to parental consent for immunisations, showing knowledge of the Australian legal requirements for consent, particularly in cases of joint custody, and outlining appropriate steps for the patient, including potential mediation and or legal action if needed. The communication, I think, was done really well there, showing that empathy, addressing the father's concerns, but also explaining the complexities around this. And reinforcing that there is actually specific ways this has to be done. Good use of handouts, evidence-based guidelines, acknowledging that the evidence is usually for giving immunisations. In fact, this is a situation that came up a lot during the pandemic because there were rules that came out that said kids had to be vaccinated as well, and of course there was a lot of conflict around that. The cases that did go to the Supreme Court, it was overall to say that yes, the children can be vaccinated, and of course that happened. And final note there is, thank you. Sorry, I thought better give it a try one last time. Yep, you did well done. Of course, we have one last case before the day itself. And so if anyone does want to give it another shot, in fact, if you're happy to give me a moment, I'm just going to reset the link in case of, no one else jumps in. If I will unpin that link, I'm just going to reset the Zoom in case Demir wants to jump in. This is where I probably needed to have some hold music or something. So now, while I'm getting this done, let's have a quick chat about preparing yourself the night before and on the day. I want you to make sure you give yourself a nice night of sleep. I want you to prepare a good breakfast the morning of. Something that's going to keep you going, potentially a strong cup of coffee to make sure you are ready on the day. Try and have some water handy as well. As you're probably hearing myself, because I'm struggling to get this working. As we do get nervous, as our mouth dries out, we start to make more of these sibilance type noises, slippery snakes. Doesn't sound nice on the microphone, as I'm sure you've all just noticed, and now the S's are all you're going to hear for the rest of the night. So having little sips of water can be really, really good to actually help decrease those sounds. And while it's a stupid little thing, it is all those little biases. Well, you're just seeing behind the scenes there as I move the screen across. All those little biases that actually can make a difference in terms of the way the assessors view your performance on the day. As we've said before, I want you to make sure you set yourself up in an area with a wired internet connection. Do not use Wi-Fi. It'll work every single day except for exam day. So always have a wired connection. Try to have lots of light for your video. I've got lights all around me here to try and make the video look as pleasing as possible. But audio is king. People will tolerate a lot of bad video, as long as the audio's sounding good. Now, almost set up, sorry guys. The next thing I want you to remember is that nerves will get you, but feel free to take a deep breath, have a pause, and get yourself running again. There is always the opportunity to reset, take control of the station again. And in the link is the new, in the chat is the new link. If Demir, if you want to join, or if anyone else wants to jump in, I am more than happy with that. Now, again, the exams, they take a long time, so be easy on yourselves, pace yourselves, and just get through it one case at a time. And Demir, can you hear me? Oh, I'm muted every time, I tell you. Can you hear me?
Yep.
Beautiful. We'll give you remote control of the screen. You can see the case on the screen. This is the last case. So there we go. New case should be up. Let's put 5 minutes on the clock and your time starts now.
we go.
You have 30 more seconds of reading time, but you want to start? I'm happy.
Yeah, let's go.
Sounds good. So, what would be your main differential diagnosis and key differentials to consider?
Okay, so I broadly break it up into dementias, dementia mimics, and organic causes. So dementias are my Alzheimer's, frontotemporal, vascular, and Lewy body. My dementia mimics are multiple systems atrophy, normal pressure hydrocephalus, progressive supranuclear palsy, and Parkinson's disease. And then in terms of organic or other, would be mental health, so depression, anxiety, primary psychosis, extremely unlikely. Bipolar disorder. Hearing deficit, vision deficit, hypo or hyperthyroidism, B12 deficiency, malignancy, in particular brain mass, medication side effects, and substance use. Tertiary syphilis is also differential for organics.
What further aspects of history would you ask Thomas and Margaret to help better understand their concerns and the most likely diagnosis?
Yeah, okay. So first I want to get a, give me a second. I'd want to get a sense of Thomas's medical history, chronic diseases, medications, his own allergies. I didn't see anything listed there. I'd want to get an idea of their social setup. So where do they live? Is it their own dwelling? Is it a unit? Who do they live with? Whether they have any services in place, whether there's any next of kin, helpful neighbors, kids who are helping them out. What Thomas's day-to-day is like. Is he still puttering around on the farm? Is he volunteering, men's shed, playing bowls, sitting at home? Physical activity level. A bit about his diet. Is he getting leafy greens? Is he getting red meat in there? Or is it just tea and toast? Whether his alcohol level, alcohol consumption level, he's smoking, any substance use. Whether he's driving or not. Then I'd delve into the 6 aspects of dementia. So there's a few already listed, but we're talking about visuospatial. Is he getting lost in town? Is he getting disoriented to surroundings that he is normally oriented to? Memory, is he forgetting things, forgetting where he left his keys? Repeating questions, some of that's already mentioned. Language, is he forgetting words that he used to know, can't remember the name of a simple item. Complex attention, this is things like completing a task with multiple steps in it. Forgetting to buy things at the grocery store without a list. Complex planning, that will be making his appointments, not being able to plan a trip or a camping trip or a trip up to a big town, something of that sort. And social, is he withdrawing from his normal social circles, no longer going to men's shed, no longer going to bowls, things like that. And then I'm running through my differential and seeing if there's anything pointing to one particular cause. So frontotemporal.
What initial investigations would you request to assess Tom's cognitive decline?
Sure. So I would be requesting blood tests for my organics, so my thyroid function, B12, CRP and ESR, full blood Es and LFTs. I do a CT non-contrast of his brain, looking for mass, looking for involutionary changes. Syphilis serology, urinalysis, let's start with that. I don't know if Montreal Cognitive Assessment is part of the investigations or not, but that's what I'd run. That's probably where I would stop investigation-wise.
how would you approach management if the initial workup suggests early stage dementia?
Right. So management is pretty holistic here. In terms of pharmacology, if there's a vitamin D deficiency or something, which is something else I should have requested, and calcium, if there's any deficiency, we can top that up. But mainly it's probably going to be one of the possible Alzheimer's meds, like memantine, but that's to be started by a specialist. And I'll get back to that. What we would do is he'd probably need a home care package assessment, him and his wife, Margaret, to see what services they need in place now that he's not able to do certain things. Maybe he was the only driver in the family, things like that. He, as per WA laws, it's his responsibility to notify the Department of Transport that he has dementia, and he'll need yearly assessments. This is not to say I'll be taking away his driving license on the day. I don't do that too much. Home medicine review would be helpful if he's on more than five or more medications, and that can be done by a pharmacist. I would provide education briefly to start with, more on our follow-up appointment in 2 weeks, on what dementia is, that it's a progressive disease, that it doesn't really get better. There can be dips with infections, but mostly it's going to be a general decline. There are set things you can do to slow the process down: good diet, exercise, memantine, controlling vascular risk factors, but mostly it's going to be a sort of a slow downhill. Unfortunately, written information, I would link them in with Dementia Australia and make sure they are part of that organization, because they get some good supports from that. If there are any defects in terms of low mood, if there is difficulty with walking or gait, allied health referrals can be done through a care plan to physio or psychology. And the main thing to do is to send him to see a dementia specialist or a gerontologist up at the hospital for a formal diagnosis and initial pharmacological treatment. Just let me have a think. I'd also mention thinking about an advanced health directive, and or assigning an enduring power of guardianship and attorney to kids or trusted next of kin, if and when Thomas becomes not capable of making medical and financial decisions for himself.
Now, you mentioned that you may find reversible causes. Are there any other reversible causes you can think of that you would want to address for this case?
Apart from the ones I already mentioned before.
Mm-hmm.
Well, any potential dementia is a potential delirium. I'd be hesitant to call a 12-month process delirium, but electrolyte disturbances and infections can cause that and could be corrected. I guess I haven't really mentioned multiple myeloma that can cause fogginess.
And did you want any of the questions read again? Or is there anything else you would wish to add?
Well, I was going to give you more targeted history based on the differentials.
Yep, definitely. Far away.
Okay, so I mentioned frontotemporal. We'd be looking for personality change, disinhibition, gambling, buying really expensive, unnecessary things. Vascular is mostly would be looking for more of a stepwise progression instead of a gradual thing. It's a big chunk, then big chunk again, then big chunk again, and would be looking for vascular risk factors, blood pressure, smoker, ex-smoker, diabetes, high cholesterol. The dementia mimics tend to give you motor problems, wide-based gait for the first three, bradykinesia, rigidity, resting tremor for Parkinson's. And ask him about his hearing. Does he have any hearing aids? They usually have hearing aids, but don't wear them. Vision. When's the last time you've been to an optometrist? Let's check your vision. Thyroid, constipation, diarrhea, feeling hot, feeling cold compared to everyone else, weight loss, weight gain, lumps in your neck. B12 is primarily diet related, but thinning of skin, bleeding gums, numbness, tingling in your feet, in your toes. Peripheral neuropathy. Cancer would be weight loss, fevers, night sweats. Brain mass would be headache that gets worse lying down and at night. That's persistent, not responding to simple analgesia. I'd go through his meds, see if there's anything sedating potentially there, and remove it. And substances, well, I'll see if he uses anything, but I don't expect him to. I don't know, you got me stumped. I'd probably offer to have a follow-up appointment in 2 weeks and bring some rallies or someone they trust with them, for breaking the bad news, for some support. I don't know. Let's just end there.
Excellent. This is another one of those cases where, yeah, sometimes you just have extra time at the end. Very well done. In fact, even Chat's jumped in to give you a good job as well. Yeah, this was a pretty clear-cut, straightforward case of how do you approach and manage dementia. So I really liked your differential list. All very sensible. I like that you kind of broke down the things you'd be looking for as well. Because that actually tied into that next question of what further questions would you be asking. You'd already actually answered chunks of that. By the time we actually got there. I also really love that you went in and actually mentioned, assessing their sleep quality and if need be intervening on that, because that's such a massive part that often actually does get overlooked. So big tick in the win box for that one. The screening, again, you ticked every box. The Montreal Cognitive Assessment as well is absolutely fantastic for these kinds of things. I think a lot of people fall back to the mini mental or GP cog. Yep, I'm with you on that one. I think you get so much more useful information with the mocker, and I would strongly encourage everyone, if you're not familiar with using it, please get to it. And starting off as well with a non-con CT brain, fantastic. In terms of the management, as you said, it's that multidisciplinary approach. Many hands make for lighter work, and again, one of the things that was emphasised in this is also acknowledging that here we really have two patients. You've got the patient with the disease, but also the wife who is now the de facto carer. And I think that was good that you acknowledge that, and bringing in, seeing what other services we can get in place. So a really important part, and also love that you mentioned we don't have to take away this man's license. a lot of people with dementia are safe to drive as long as appropriate safety checks and balances are in place with those reviews to make sure that things continue to be safe. Sometimes even as things do progress, we do put on the restrictions of, only driving certain hours, certain distances, familiar environments, but I think it's a oversight that some people fall into the trap of. Dementia means they can't drive anymore. You're in Western Australia. Are you in a rural or urban centre?
Regional.
Regional? Yeah. I think you can tell because taking away someone's license is a big deal when you're not in a city. For some people, it's basically a death sentence. Very well done. There were a couple of times as well where I did interrupt, and that's the examiners have certain times where they have to ask certain questions, so don't feel like they're trying to jump in, don't feel like you're running out of time. Sometimes it's just part of the prompting, part of the schedule. And in those cases, like here, there's often time at the end where you can go back and add things in as well if you want to. If you're finding you're getting that kind of multiple times, you might need to just tighten up the answers a little bit. It may be they're after less detail and there's more questions they're trying to get through. So just bear that in mind. But otherwise, absolutely fantastic. I'm guessing you've seen patients with dementia. I don't know, call it a hunch.
One or two.
Yeah. Absolutely smashed it, mate. Again, very well done. You're going to fly through the next 2 weekends. Are you Saturday or Sunday?
Sunday.
Sunday? Yeah, you'll be fine, mate. Well done.
Cheers.
I'll leave you to it. All right, so the structured feedback for this slide, and I'll fix this up again. I'll get this right one day, I tell you. So the competent candidate here demonstrates a thorough understanding of the differential diagnoses for cognitive decline and identifying those key reversible and non-reversible causes and outlining appropriate investigations. Describing the management approaches that include non-pharmacological and pharmacological, and communicating empathetically with the patient and spouse, acknowledging that that spouse is as much a patient here as the patient themselves is. Having that clear and supportive explanation and kind of follow-up plan, I was very happy again. If nothing else, always remember, always book in a follow-up appointment. Use the refs mnemonic to give you that little prompt right in the corner of every page. Always mention what are the red flags, what's the follow-up plan, when are we going to see each other again to follow up on this. It's the joy of general practice. We have sessions, we have multiple occasions we can see these patients. And of course, following along the evidence-based guidelines for this. All right, so well done to both of you for jumping in tonight. I appreciate it's pretty nerve-wracking. You probably have other things you want to be doing at 10 o'clock at night, but hopefully you found those cases helpful. Again, a couple of curveballs in there to get you thinking a little bit more outside the square, thinking of things that you may not have read up on as much or thought much about. And so this is the perfect opportunity to actually get on now and read up on those topics. Just familiarize yourself with some of that content if you're not already. I'll hang around for another little bit to just see if anyone wants to jump into the chat to say anything. I can see we've got a few people watching tonight, which is always fantastic to see. We have a note here from Kashminder. Thank you so much, Kane, for all your help. My absolute pleasure. I know I struggled with the KFP exam, was so frustrated by the lack of free resources and was keen to start throw things together to put it out there and get people through as well. Now, if you want to throw into the chat, if there's anything in particular that you're nervous or worried about or something that you feel might kind of set you back for the exam, I'm happy to hang around for a little bit and just have a bit of free-form chat around this topic. Otherwise, if people don't pop anything in, that's fine as well. You can go to bed or enjoy the night or do whatever it is normal people do at 10 o'clock at night. Of course, you do have days left. Hopefully, you've got some time off work between now and the exams as well. The next big hurdle, of course, once you get through the next 2 weekends is the wait. Oh, hang in there. It kills you. It's something that feels like it takes 10 times longer than it does, than it needs to. It is a very difficult process to actually go through, mark and standardize all these. And so you have to just hang in there. get through to the results day. And of course, once that is through, you guys are going to get fellowship. It's going to be great. You've made it through all this far. You're so close, you can probably taste it. I hope as well that you're already thinking about or have in the back of your mind what to do after fellowship in terms of moving from a pardon me, moving from a employee usually to an independent contractor. If you haven't already engaged a financial advisor or have an accountant or someone that you can bounce through, if you don't have a business mind or haven't had to deal as a sole trader before, that you have these chats, start getting things organized now, because you don't want to actually get your fellowship and then find you're having to struggle to get all the finances ready before you can actually start working. Some places you may work at, where I work at the moment, for example, you actually need your own FPOS machine. The facility itself doesn't provide it. You have to bring your own in. So if you're not familiar with these kinds of pitfalls, now is the time to find those out. Likewise, if you're not intending on staying at the practice you're currently at, now is a perfect time to start putting the feelers out and just see what's available in any of the regions you may wish to work. If you are leaving the practice you are in, it's always really, really nice and really, really helpful if you have a few summaries for some of the more complex patients to leave behind in the notes, just so other people can actually get a quick idea of where you got to with those patients, where investigations or management plans were up to, and that way they're not having to hunt through dozens and dozens of previous consultations. Of course, you hopefully have seen some like that at places you've worked before, but often you know the difficulty of seeing a patient for the first time and having to muddle through, try and get your head together of where everything is at. I don't know about you guys, but I tend to attract kind of the heart sync patients and the more complex medical patients, a lot of mental health and gender diversity, which is, again, one of the joys of general practice. And so I think it's always good to make sure, if you have to pass the baton on, you've actually got options there. Now, a very interesting comment has just come in from Demir about, are you using Lyrebird or Heidi? So I really have used both. In fact, I've used other ones as well. I agree that both Heidi and Lyrebird are probably the best ones at the moment, but I will say there's a couple of other very close candidates. For those that aren't familiar, it's a large language model, GPT, that takes the audio from a consultation, transcribes it, and summarizes it for the records. They're absolutely fantastic, to be blunt, particularly if you tend to have patients that come in with 5-6 different problems. To be able to have that summarized for you at the end of the consult is incredibly time saving and lets you actually get back to seeing the patient. The big thing I'll say on this topic, though, is make sure you actually read what it puts out, because often you do need to fine tune it and actually correct some of its mistakes. I will say I have seen Heidi actually make up some examination findings or presume some examination findings. And so please, if you are using that one in particular, make sure you have a look and catch that in the act, and don't include things in the patient records if it isn't actually factual. More than welcome, Michael. Now, for those that are using AI and all this kind of technology in the practice, really good to see. For those that don't, I strongly encourage you to just play around with it. You can install it on your laptops. Heidi, for example, is free to use in a basic form. And play around, and the most important thing is to break it, to find out where it doesn't do well, because those are the things you need to keep an eye on in particular, and to see what it can do and what it can't do. A lot of them now you can actually train to do different bits, so that if you're filling out forms on a regular basis, you can actually input some of those forms and have it fill it out for you as you go along. Question here from Kashminda, any tips for statistics? So there used to be questions in the CCE exam where you were given a scientific paper before the exam, and you were then grilled on the day about questions specific to that paper. That is no longer the case. You can get, and we've had last week or week before, questions where you'll have sections of a paper taken out or tables from a paper taken out, and you have to then apply that to a clinical scenario. Those are fair game. The key tips that I would advise you to keep an eye out is look and understand what a p-value is, look and understand what your confidence intervals actually mean, and always ask yourself when you're reading any kind of paper is, does this actually make sense? Would I actually apply this to my patient cohort? And is the evidence actually valid and backed? Is the study sufficiently powered? Have they actually got a large enough population that they're assessing, or a diverse enough population to actually reflect what happens in real life? Peeling back the curtain a little bit, I was a biochemist and molecular biologist before I became a doctor. Doesn't get you invited to as many parties as you might think. So reading through journal articles is a big part of my previous life. Try not to get too caught up on the fine details for these exams. They acknowledge that it's going to be under very stressful circumstances. And so try and extract from it what is the actual message, what is the big picture that they're trying to get out. But you should have a working understanding of things like p-values, confidence intervals, number needed to treat, number needed to harm, and odds ratios, likelihood ratios. If you don't have a basic understanding of that, there's a bunch of different YouTube videos that have like 15-20 minute summaries. And so just jump on, smash through a couple of those, and grab a couple of papers and ask yourself, do I understand what each of these tables or values actually mean? Now, another question here is, fellowship ceremony, how do we apply? You'll get emails, basically. The fellowship process itself, once you have your exam results, there's actually a link for a form on that same page, really, that you used to have to go through and fill out a whole bunch of stuff. Thank goodness they've scrapped a lot of that, so it's a very streamlined process now. You'll get emails, you'll get information sent out to you. You just have to follow through. And there's a email address you can contact as well, that if you have a question or aren't 100% sure, you just contact, and I've got to say they're quite responsive in actually getting back in a timely fashion. No other comments coming through the chat. So, look, I will wish you all well then. Have a good night. Best of luck for this weekend. You're all going to absolutely smash it. Actually, we do have a couple of people still here. Do you want another session next week, or do you think you might be a bit crispy and burnt out by then? If you want to throw anything into the chat, I'm more than happy to put another couple of cases together. But at the same time, I appreciate you probably want the week off. You're probably doing some cases this weekend, and that might be enough for you. I will tentatively pencil something in then, and I'll put a post up. I'll put a poll up. There we go. How's that? We'll use technology to our favor. And if you guys want to say yes or no in response to that, we will leave it there. All right. So catch you guys next time. I'll get a couple of cases prepared anyway. Oh, actually, something I do want to mention is on the website, which I had a thing prepared, but it's gone now. Here it is. On request, I have actually uploaded the PDF files for all of these cases up onto that website, so that probably not as helpful for you guys, but if you know other people that will be sitting the exams after and just want to do some practice on their own, they can jump onto that website. There's a link up the top for exam prep, and in there is a bunch of the CCE cases. So have a look, see if it's useful. Otherwise, throw it in the bin, I guess. Do whatever. After the next weekend, you can burn all of your CCE resources and move on with your life. Until then, though, see you guys.